If you've ever had a painful lump, swelling, or recurrent abscess right at the top of your butt crack that just won't go away, this video is for you. Today on Knife Skills, we're talking about pilonidal disease, a surprisingly common condition that a lot of people suffer from in silence. On this channel, we've covered hernias, gallbladders, and other well-known surgical problems. But there's one condition I see constantly in my elective practice that doesn't get nearly enough attention. It's sensitive, and it's in a sensitive area, and many patients live with it for years before getting the proper help. And that's why I wanted to make this video. I'm gonna take a little departure from my regular videos. It's gonna be a lot more information and a little less fluff. In today's video, we're gonna cover what is pilonidal disease, the main causes and risk factors, and some of the treatment options from simple to more complex and surgical. So let's dive in. So what is pilonidal disease? Well, it's a chronic skin condition that occurs in the natal cleft. It's that crease between the buttocks, right near the tailbone. You may hear it called pilonidal cysts, pilonidal sinuses, pilonidal tracts, and pilonidal abscesses, and these are all really variations of the same problem. They really don't have a different meaning. At its core, the condition involves a small pocket or tunnel underneath the skin, and these pockets often contain hair, skin debris, and pus. Over time, they often become infected, they can drain, and are often incredibly painful. One of the classic signs you'll see on examination when a patient has pilonidal disease are these small little pits or opening in the skin of the cleft. These are the entrances to the sinus tracts underneath and are like a critical part of this diagnosis. When things flare up, the patients can develop painful swelling, drainage, and sometimes even a fever. And pus and drainage is often the problem that ultimately gets people to seek medical attention. So next, what causes pilonidal disease? Well, I'm gonna be upfront with you. This is one of those diseases where we really don't know the actual cause. A lot of people have theories and will sometimes tell you they know exactly what caused it, but in truth, they don't. Some of those theories include that it's purely an embryological defect. Others believe that it's caused by occlusion of the hair follicle that prevents hair from erupting properly. Some suggest that the deep gluteal cleft creates a suction force that pulls hair in. Others point to friction, even going back to the old theory that soldiers running around in Jeeps and that friction from the seat of the Jeeps would cause their pilonidal disease. There's some that even go so far to say that the cause of the pilonidal disease is hair trimmings from haircuts that fall down and get stuck in the gluteal cleft. On top of all of that, there are hormonal factors. It's much more common during puberty. It's also much more common in men than women, but women get it too. And the reality is that no single explanation seems to cover all of the things and all of the factors that are going on here. To me, I consider pilonidal disease actually a part of a follicular occlusion tetrad, which is a group of conditions that is difficult to pronounce, and it's gonna take me a while to get through this part of the video. The first one is hidradenitis suppurativa. The second is acne conglobata, which is a very rare and severe form of acne. The third is dissecting cellulitis of the scalp, something finally easier to say. And then finally, what we're talking about today, which is pilonidal disease, which is the most common of the group. So with that part out of the way, let's talk about treatment. Not every case needs surgery right away, but many eventually do because the condition has a high recurrence rate if you just try to treat the superficial infection. So let's start with initial management. This is what happens during the first episodes and the first encounters with doctors. Oftentimes, doctors will end up prescribing antibiotics because they'll see a superficial infection. Overall, it's pretty ineffective, but it's a common treatment because for most doctors, there isn't much more that they can offer. And the anti-inflammatory properties of antibiotics can't help, at least initially. If it's worse and you present to the emergency department, sometimes doctors will do an incision and drainage of the abscess. That'll help relieve some symptoms temporarily, but it doesn't actually solve the underlying problem. Other things that are often suggested are improvements to hygiene, hair removal through lasers or shaving, or sitz baths and good wound care. All of this can help improve the symptoms, but none of them really treats the underlying problems. And so it's often not enough. Very often these will become a chronic condition and then will present to the surgeon's office. In this case, if it's more chronic, surgical treatment is usually the best option. And the goal here is to remove the entire sinus, the tracts, and the pits so the problem doesn't come back. Common surgical approaches include a simple excision with healing by secondary intention. And in fact, this is actually very often how I start treating patients. I'll oftentimes use a skin punch to remove the tissue in the nasal cleft, and I'll remove the entire tract over multiple visits to my office, each time just punching out a small amount of skin and allowing it to close on its own. This allows patients to go to work the same day or live life pretty normally without too much interruption from a surgical procedure. Other times, we might remove the whole area and close the skin primarily. And when things get a bit more complicated, we'll do things like flap procedures. For example, the Limburg flap is something that we'll do, and that's designed to remove all the area and flatten the gluteal cleft a little bit to reduce recurrence. So the choice that a surgeon will decide on really depends on the extent of the disease, whether there are previous surgeries. A lot of patient factors come into play. Patient preferences are something that we consider as well. And in my office, I always tailor the approach to each individual because something that works for one person won't work for the other. There's really no cookie cutter approach to this operation. And recovery varies. Some people, if they have a larger procedure, will be back to work just within a couple weeks, and others need more time off. It really depends on the size of the procedure, the size of the flap, and the amount of disease that they have. What's really important is to prepare patients' expectations. Recurrences happen, complications happen, and very often it requires multiple procedures before you're finally cured of this condition. So my final thoughts. Pilonidal disease is a frustrating, painful, and often difficult to manage condition for patients, but it is treatable, and with the right approach, we can finally get lasting relief for many of the patients. So if you know someone who's been dealing with recurrent issues in this area, don't suffer in silence. Seek a surgeon who has experience and interest in taking care of pilonidal disease. Not every surgeon loves doing these cases, but those who do make a massive difference. If you enjoyed this video and it helps you understand pilonidal disease better, give it a thumbs up and share it with someone who might need it. I'd also love to have you drop your questions or experiences in the comments below, and we can get a discussion going about this often not talked about disease. If you want to see more surgical topics explained on this channel, hit the subscribe button and notifications so you don't miss the next one. Once again, thank you for watching Knife Skills. My name is Dr. Richard Hilston. Have a great day.